Hi, I'm Heidi Nelson, CEO at Duffy Health Center, and welcome to this edition of Duffy Doings. This is our show about issues relating to healthcare and homelessness on Cape Cod and what's going on at Duffy Health Center. Today we're going to be talking about healthcare for the homeless and what is the healthcare for the homeless model. And we have two experts here today from our Duffy Health Center staff. Arlene Crosby, who is Outreach Case Manager at Duffy. Hi, Arlene.
Hello.
And Sue Wasilek. Sue is a family nurse practitioner at Duffy. I always say our claim to fame is that we started on the first day together, September 1st, 2010. It's good to see you, Sue. Thanks for coming.
Thank you.
So the history of healthcare for the homeless really dates back to the awareness of homelessness in our society. If you're old enough to remember the decade of the 1980s, you know that there was a lot of awareness of homelessness. It felt like a wave and generated a lot of concern among the general public. People speculate a number of different reasons. One is deinstitutionalization of people with mental illness, which helped to increase the number of people on the streets, and also a dramatic reduction in funding of affordable housing and public housing in this country. So spontaneously around the country and in different major cities, healthcare for the homeless programs started up, like in Boston, our big brother, Boston Healthcare for the Homeless, but in other cities like Baltimore and Miami and San Francisco, Chicago, Seattle, all over the country. And the federal government, Congress, recognized that this was a model, and we'll talk about what are the elements of the model in a minute, but this was a model that was really important in order to address the very significant needs for healthcare services that people who are homeless have. And so they funded the Healthcare for the Homeless program. This was after the Robert Wood Johnson Foundation funded a major demonstration project across the country. Here on the Cape, the awareness happened as well in the 80s, people starting to experience homelessness on Cape Cod, which was equally shocking to people who live in this beautiful place. And Arlene, you were around at the time at the creation of the NOAA shelter. Do you want to just say a few words about how NOAA came about?
Sure. Well, it was pretty obvious that there were several veterans that were wandering the streets, main streets of Hyannis. And also, as you mentioned, the people who had been discharged from some of the institutions and had nowhere to go. And so I remember that Paul Hebert, who used to be in charge of Champ Homes, and he's an amazing man, he was like, well, we have to do something about this. And I won't make this a long story, but what happened was they used the armory for a little while, and the first person on South Street, and the first person to go through there was one of my former clients, and he was a veteran and very, had a lot of trauma experience. And so HAC finally stepped to the plate.
Housing Assistance Corporation.
Thank you.
Yeah.
I'm so used to acronyms.
Yeah.
And they had a donation from the Chase family and started the NOAA shelter.
Right.
Yeah,
And
a lot of fun, yeah.
Our roots go back to then a little later when nurse practitioners who worked at the Visiting Nurses Association, when their patients who were homeless were discharged from the hospital, would go to stay at the shelter. So those nurse practitioners would go to see their patients at the NOAA shelter and found this huge unmet need for health care. And they recruited volunteer physicians to come and help them. And so a broom closet was cleaned out to become an exam room, and that's how Duffy Health Center started. So we're really
was a broom's closet,
part of a local effort, but also part of a national movement. So let's talk about that model, about healthcare for the homeless. What do you both, from your different perspectives, case management and being a medical care provider, what do you see as the major elements for healthcare for the homeless? Arlene, do you want to start?
Trauma, poverty, untreated mental health issues, medical issues that haven't been addressed. Well, you said domestic violence, and that is a big piece.
Well, and actually, forgive me, you're right. We should start off with talking about what you see as those health needs that are unmet. Why don't you start there?
Sure. Well, You know, there was a study done in the United Kingdom that showed that homeless individuals wind up dying on average 30 years before someone who's not experiencing homelessness, and there are so many reasons for that. I mean, first, as we get older, most of us have to manage different chronic health diseases, and the homeless are the same, so diabetes, hypertension. But there are other nuances and other layers that really complicate the healthcare for homeless people. Number one is being vulnerable, so people who have experienced domestic violence, the fragile elderly, the illiterate, the LGBT community, are the veterans, certainly, are all vulnerable populations that are more prone to experience homelessness at some point during their lives. Then there are mental health issues and substance use disorders that certainly complicate and cause their own issues as people age. And then I would say, specific to being homeless, there's environmental concerns. Walking around in the same pair of boots all day, being out in the rain day in and day out, having to walk many miles or bicycle many miles, can cause skin infections, musculoskeletal disorders that we see quite commonly. And lastly, living in congregate housing or collective housing, germs spread like wildfire.
The flu and
so lots of infectious
upper respiratory infections,
etiologies there.
Now let's go back to the elements of HA. So now we know what those issues are, the health issues that we're trying to address. So what do we see as some of the elements of the model of healthcare for the homeless that address those issues? Do you want to start, Arlene?
Sure. Well, one of the things is outreach, which I think is very important. And I think that let me just put this succinctly if I can. So Duffy is very special because we have the mental health, we have the medical, we have the MAP, all of these programs. And they evolved with working with our people for so many years into what it is today. And I think doing the outreach and educating people and providing dignity and respect to the people that are outside in camps, cars, beaches, I think it's just made such a difference, and we are well respected for the work that we do in bringing our clients in and referring them to other agencies. I hope that's what I'm supposed to say.
So integrated care is part
integrated
of the model.
care.
And when I think about our history, we started out as a primary care provider, but it doesn't take long to figure out that, wow, there's schizophrenia and certainly major depression amongst these folks, and they need counseling and they need medication, psychiatric medications, and then obviously drugs and alcohol, but also just they need housing.
They need housing.
Homeless people need housing. And so the three-legged stool is the primary care, the behavioral health, and the case management, which are the three pieces that we have at Duffy. What would you add to that?
I think that we all wear the glasses of trauma-informed care, just recognizing the fact that because of their life experiences, people are not necessarily trustful of authority or just convention, however that manifests. And so being able to honestly meet people where they're at, whether their perceived need is housing, whether their current need is substance abuse treatment, whether they are schizophrenic and really need to be fast-tracked into psychiatric care. When we wear our lenses of trauma-informed care, we can direct people as per their own stated goals, which I think is really important.
Listening.
And other techniques like motivational interviewing. So if you know that somebody's apt to withhold information because of the lack of trust, because they've been burned so many times in the past, and because they've had, as a result of many, many, many traumatic relationships in their lives, to be able to use interviewing techniques to coax information out of people and get them to trust you.
And one of the things I love about the model of care we provide is there are so many touch points. You know, if you there are case managers, and I like to think that all of us perform high-intensity case management with and for our clients, but in different ways. The medication-assisted treatment with its nurses, who are those case managers, honest housing case managers who are helping people with the nitty-gritty of getting ID cards and transportation, and then medical, where we all function both independently and as a team to try to really address the needs that patients have at any given day.
Right, very good.
Yeah.
I like to tell the story when I give tours of Duffy, that even our registration staff, our front desk, the person that you first interact with on the phone or at the window when you come in is somebody who's been trained in trauma-informed care, and that our registration staff, we call that program Connections, because part of what they do, in addition to finding out your age and your your address and all of that kind of information, is to find out if you've, did you have something to eat today? I heard one of our MAs ask a patient as I was walking by the exam room yesterday, did you have anything to eat today? And it was 1 o'clock in the afternoon, and he said, nah.
Right.
So just those kinds, like you're saying, every little touch point in addressing an immediate need can be just as powerful as getting somebody psychotropic medication for their serious mental illness.
Right.
So, so outreach case manager, you do a lot of work. We created a position, given the concern in the community about tourism and creating a really pleasant environment on Main Street in Hyannis, and that's important to all of us, that we have a clean and healthy and safe community. So we created a position of outreach case manager that works hand in glove with the other outreach agencies and with the Barnstable Police Department. Do you want to talk a little bit about that?
Sure. So I work with the Barnstable Police Department at, we meet once a week with other agencies, VinFin, St. Joseph's House, and a few others, and we meet to discuss clients that are in most need and we're really worried about. What can we do? Are they keeping their appointments at Duffy? Does someone need to go to court so they don't have to worry about that? So the most vulnerable people are the ones that we talk about. And last summer, I worked closely with the Barnstable PD and VinFin and Housing Assistance Corporation. A lot of work was done in camps surrounding downtown Hyannis and some in Yarmouth. The wonderful thing about it was I think we were able to make it a better place for the tourist and also keep the people that are homeless and struggling in a safe environment and without being, looked down upon for being homeless. It was quite interesting, and they took our concerns and our thoughts for them, and we were able to make plans so that people just didn't have to always hang around and just not have a purpose for any,
Yeah, and it's just extremely touching to see these police officers that have gone through a lot of training to know how to deal with people who are having the issues that our clients face. Now, no kidding, they jump to attention when somebody becomes belligerent or dangerous or lashes out. They become police officers. But it's just very interesting to see how they interact with the people that we serve.
So we do have a coffee. VinFin sponsors it right now, and Monday and
the coffee house.
The coffee house, yes. And honestly, at first people would say, "We're not going to go if the police are going to be there. We're just not going to go." And they're there all the time, and people are going up. Ones with warrants, lots of different issues. Who said they would never, trust an officer. So that's a wonderful thing to see.
And they wear their uniforms,
Yes,
which I think
of
is
course,
interesting because in some communities that have that kind of program, the officers wear plain clothes, but I think it's kind of interesting to establish the connection that just because it's a police officer in uniform doesn't mean that you have to be afraid of that person. So Sue, so Noah Shelter became St. Joseph's House, and that's part of your job is to provide primary medical care services to the people at St. Joseph's House. So talk about that a little bit, and I'm sure that you're limited in what you can do at the shelter, so how you engage those folks to get them over to the clinic where we can actually do more.
Yeah. I think The most important thing I do over at St. Joseph's is just like a police officer showing up in their uniform. I just try not to be scary.
Do you wear a nurse's hat?
I don't. I wear the universal sign of the stethoscope.
There you go.
Just
Perfect.
And you know, and it's really about being in community with the folks at St. Joseph's, making the connection, having conversations, building rapport, building trust. And once they entering into those conversations, inserting bits about healthcare and their goals for their healthcare. And as those conversations and that trust evolves, the natural segue is, well, then come to the clinic.
Yeah.
I refer to myself in the clinic. You know me. I'm not that scary. Come on in and we can, you know, do something a little bit more in depth. And sometimes it takes years to get them to walk the 4 blocks or whatever it is. And those are huge successes.
I think another thing that I've admired about your work over the last year is that since Catholic Social Services assumed management of the shelter, and that's when it changed their name to St. Joseph House, they had experience with new models of medication management that we hadn't even considered before, which were really, really useful and helpful to us. So they, those patients that have psych med needs in particular, but other kinds of medications, receive visiting nurse services at the shelter.
Yeah.
But talk about what your role is in that part.
Well, there's a couple different things that I do. I think on one hand, it's when a new client comes to the shelter, they could be coming from anywhere. They may or may not have medical records. They may or may not be taking medications. And so becoming a super sleuth and helping the shelter understand the medical, psychiatric, substance abuse needs of that particular client becomes really important. Amassing the records, making a plan that I can communicate to the staff so that to put them at ease and to know that this person is safe to be in a collective living environment.
Right.
I will suggest and communicate to those visiting nurse associations directly or to shelter staff directly when I meet someone who is high needs, high risk, might need a little bit more of a helping hand to get them involved in those medication management services quickly. And conversely, those nurses come to me when those medications are running low.
Right.
When they are seeing the client either exhibiting behaviors that could be better addressed with some medication manipulation, or when they've heard the client express to them that they're unhappy with how things are feeling in the moment. If I can manage it myself in that visit or at that time, I do. And if I can't, well, then we go out from there to our own psychiatric staff at Duffy when I have questions that I need a little help with answering on clients' behalf. So.
Right. Well, and whereas before it was a paper process of faxing,
Oh, yes.
you know, you're the primary care provider, and so for them to see the patient, they have to have, you know, some kind of authorization from the primary care provider. But if you're standing right there face to face, it's a beautiful thing.
It's a beautiful thing. You know, I think a lot of it speaks to just trying to get rid of as many barriers and boundaries and obstacles and bureaucracies as we legally and professionally can to make it as easy for folks who are under high degrees of stress and a shelter that's managing the needs of a lot of different patients to get what they need.
Right,
Yeah.
right. So, Arlene, I'd like to talk a little bit about In From the Streets. We were mentioning the population that you tend to work with, who are people that either staying at the shelter or living in the woods and in places that, as HUD, Housing and Urban Developments, is not meant for human habitation, I guess that's the word. That they, when we have a severe weather event or when we have a cold snap, as we sometimes do here on Cape Cod, we have a fund that Duffy is in charge of. It's shared by the entire community of service providers, but Duffy is the fiscal agent. And historically, It's involved the United Way. The United Way puts up about half of the funding, and then Duffy, on behalf of the collective, does fundraising with the various towns across Cape Cod, and 7, 8, or 9 of the towns will make contributions to In From the Streets, which allows us to provide temporary housing for people who are medically fragile. Do you want to talk a little bit more about In From the Streets?
Sure. Last year we had a horrible year with weather, and of course we have to.
We had what, 4 nor'easters?
I think
that's
so.
what-
It just went forever. It didn't
Yeah.
kind of stop. But there was a mother and son who, they were waiting for housing, had been looking for housing. The shelter was full, and they had no place to go. Very little income, but so we put them up, and 2 of us worked with them on, getting benefits, just getting a plan of care. And the son ended up going to treatment, which was a wonderful thing. And I don't know that he would have done it because he was afraid of what was going to happen with his mother, didn't want to leave her. And so we were able to assure him that we would keep her safe. And she actually reunited with family. And so the son went on to sober housing. I don't know today, but it's all about being in a safe place and being able to work with a case manager and the whole team at Duffy and other agencies such as FinFin and Housing Assistance Corporation to come up with a great plan so they can move forward. And then, there's a few that are just so compromised, so much trauma, untreated mental health, substance use. We keep them safe. And, we just keep engaging, whether it's putting them up or, out on the streets, their camps. And hopefully we'll maybe empower them to think about moving on a bit, creating a good plan.
And sometimes, obviously for us, housing is an engagement tool. When you're able to provide safe shelter for somebody, and that creates the beginning of a relationship that you can then help them move along.
Exactly.
Which is great. So, if you're interested in helping with In From the Streets, we solicit contributions from the towns across the Cape, but we also love to receive donations from churches and individuals, private foundations. So if you're interested in contributing to In From the Streets, please go on Duffy Health Center's website at duffyhealthcenter.org. It's that simple. And you can click on Make a Donation and go right through and dedicate your donation to In From the Streets. We'd be grateful.
We would be really grateful.
Sue, do you want to talk about behavioral health and the behavioral health needs of the people that we serve?
Oh, sure.
It's a big topic.
It's a big topic. I don't know if any of us can fully imagine what it might be like to have no other choice but to live in the shelter. And so we see a lot of anxiety disorders, as you can well imagine. Most people have at least one history of significant trauma. We see a lot of post-traumatic stress disorder as well. We see a lot of people who don't realize the fact or don't want to realize the fact that they have a mental health disorder, and those are some of the most complicated and sometimes take the longest, and we work really hard to stay close to those people. As you might expect, there are also higher needs of behavioral health disorders, dementia, schizophrenia, that land people in homeless situations. And so we're always have our tentacles up, we're always paying attention to those mental health needs of the folks who are there.
Right. We say in the business, in healthcare for the homeless, that poor health causes homelessness, and homelessness causes poor health. And I think as far as mental health diagnoses, that's especially true.
Yeah, they feed each other. Yeah.
And so how do you address those needs of the people that you work with, both in the clinic and at the shelter? Maybe this is a time to plug the behavioral health services at Duffy.
Sure. I think that sometimes it's as easy as listening to someone in a quiet space. So I pull them upstairs away from the fray and try to allow just some venting, some emotional presence, which I think is useful. Beyond that, we have a great behavioral health team at Duffy, and so I gently and persistently nudge in that direction, both to meeting therapy and also if medication adjustments are needed to meet our psychiatrist. Sometimes that just doesn't happen, and that's when it's really great to have a phone. I phone a friend if it doesn't transpire to get them into the clinic as quickly as one I would like, or if they aren't able to make it over there. So it's a multifaceted, patient-centered approach, and we do what we can.
Right, right. And we have now 2 full-time
Yes,
psychiatric providers.
yes.
So Dr. Field, who's been on this show, and I think Carol's been on the show too. I think we had her come early
you got
on.
her ready,
But just fabulous, you know, people who have worked with our folks for a long, long time and are very skilled in doing that. Finally, I guess I'd like to talk about right now. We use these shows on our website year round, but right now we're in the middle of winter, and we just acknowledged Homeless Persons Memorial Day on December 21st, which is the shortest day of the year or the longest night of the year, whichever way you choose to think about it. Nationally, since the 80s, the National Coalition for the Homeless and the National Healthcare for the Homeless Council have come together to recognize Homeless Persons Memorial Day, where we recognize those individuals who passed away in the prior year in homelessness, or often what we've been doing as well is recognizing people who have had many, many years of homelessness in their lives that would certainly have contributed to the conditions, even if they were housed at the end of their life. They had a very difficult and poor health due to their homelessness, which could have been a big factor in their early death. Do you want to talk about what we did this last year, how many people we recognized, and how the group worked together to pull off the service?
So we recognized 40 individuals who passed away this past year. The Federated Church, Dan McCullough
In Hyannis.
I'm sorry.
No, that's what I'm here for, to
That's
add
a
those
good
things.
thing. M25, which is Dan McCullough. We had the Barnstable Police, they were involved this year. Vinfin, like I said, Federated Church.
Oh, there was a wonderful youth group.
In the youth group, yes.
Street Reach
Wonderful.
is
Street
the
Reach,
name.
yes.
And David Freeland,
Yes,
the rabbi
the
at
rabbi.
the Cape Cod Synagogue, and Reverend Philomena
Yes,
from the Federated Church.
The Federated Church, and Jay and his partner, who had piano and the guitar. Yes, and our own Pam Wani.
Right,
Yeah.
right, who's our spiritual care provider.
Yes.
She's been on the show too.
Yes.
So
It was a wonderful night, and just remembering it's difficult sometimes for our clients, but they all want to go, to be there and just.
we had a lot of clients there this year.
Yes.
It was a very rainy, blustery
Awful, yeah.
night, and I know we were concerned that we weren't going to have a big turnout. But and interestingly, now there are groups in Falmouth
Yes,
and on the Lower Cape, Orleans, and Eastham that have started Homeless
Good.
Memorial.
There should be one in every town.
Yeah, I think
It's
you're
really
right.
touching and a really important way of being in community together.
Right, right. Well, Sue, give us just the quick, short version about how you got interested in healthcare for the homeless.
Oh, geez. Back before there was Mass Health, I might be dating myself now.
Medicaid.
Yeah. I was a farmer of very little means. I had to utilize free care at my local hospital. I met 2 fellow farmers in the waiting room who also did not have medical care. And I said, boy, I should really learn how to take care of my own. But of course, by the time I got out of nursing school, we had a lot more access to health insurance, but the social justice component of wanting to help where help was needed has always been really compelling.
Great, great.
Yeah.
Briefly, Arlene, how did you? This has been your life's work,
I know.
basically.
Well, we had the Lombard Farm, and that's where the poor people lived in West Barnstable. And we had domestic violence in the village of Osterville. And my mom was always trying to help people, and I think I sort of got that from my mom, that I wanted to work with people who could just use a helping hand.
Great. Well, Arlene Crosby, Outreach Case Manager at Duffy Health Center, and Sue Waselic, family nurse practitioner at Duffy Health Center. You can tell we love each other, right?
Yes, absolutely. Yes.
Thanks so much for being here and for talking about what we do. And that's it for this edition of Duffy Doings. We'll see you next time.